So welcome to today's class meeting. Um, let's see, we are still in module 153 in chapter 11. Our test is coming up. So we're going to continue on with medical decision making. And I've got a little presentation, of course. All right, so hopefully by the end of today, you guys have a good understanding of what is going on with medical decision making. All right, so the elements of medical decision making, or MDM, remove the focus of adding up tasks and now focus on the elements that affect the management of a patient's condition that include the number and complexity of problems addressed, the amount and or complexity of data reviewed, and the risk of complications and or morbidity or mortality of patient management. All right, so would anybody else like to volunteer to read this next section for me? This bottom section. We're shooting for some engagement, a little interaction with you guys. So if anybody would like to read that for me, I'd appreciate it.
I can read it. I don't know if you can hear me.
Yes, ma'am, we can hear you.
Are you talking about the complexity of decision making
Yes.
section? Okay.
Mhm.
Complexity of decision making is based on three elements: number of diagnoses or management options, amount and or complexity of data to be reviewed by physician, risk of complications or death, more is it morbidity
Mhm.
or mortality?
That's perfect. Thank you so much. Okay, so basically what this means is the three things that they're going to base the complexity on is the number of diagnosis. This is how many things the patient um, has going on at the time. The higher number of things or issues or problems that they have or diagnosis that they have, the higher level of complexity it is going to be. All right. And the amount or the complexity of the data to be reviewed by the physician is also going to come into play with this. The physician, if this patient has, you know, heart disease on top of diabetes, on top of a history of cancer, on top of all these other things, it's going to take them a long time to go over that patient's chart and review all of that data. And it all kind of ties together. The more things they have wrong with them, the more diagnosis they have, the more data there's going to be, the longer time it's going to take. Okay. And the third thing is the risk of complications or death, morbidity, or mortality. And this is basically just what it says. How likely is this patient to die from what's going on right now? If what they've got is life threatening, then that's going to be of a really high complexity. If it's not that serious, it's not that serious, right? Thank you for reading that. I appreciate it. All right, so the extent to which each of these elements is considered determine the levels of MDM complexity. Medical decision-making complexity levels are straightforward, low, moderate, and high. And just to break that down just a little bit, your straightforward is going to be something very simple. Patient coming in with a basic cold or maybe some allergies or something like that, something real simple. They don't have anything else going on, nothing they got to worry about as far as pre-existing conditions. It's going to be really cut and dry, real straightforward, and you're going to have just that one problem to deal with most likely. All right, low is going to be a step above that. Okay, if they're going to have maybe several symptoms, maybe a cold with some body aches, it could turn into the flu or something like that. And then you're going to go into moderate, which is going to be more. And this may be somebody that's coming in sick but has like type 2 diabetes along with it. So there's more things to start to take into consideration, right? Um, and a history of high blood pressure. Now, if it's high, that's the highest level they can go. That's going to be somebody that's really, really sick, has a lot going on diagnosis wise or pre existing condition wise. Um, and it's going to be time consuming. It's vital. It's emergent. More than likely. it's going to have a high complexity level. So it just goes up in steps.
Parents, y'all better start monitoring who y'all kids talk to.
All right. So in your book on page 278, there's this awesome table, 11-1. It says the basic elements of medical decision making. And this is basically a table, and this one is the established patient office visit, from the CPT codes that I'm seeing here, is what they're referring to in this particular table. But you can see in the different columns, they have level of NDM. They list our four: straightforward, low, moderate, and high. And then they have three other columns that represent our elements that we talked about: the number and complexity of problems, the amount or complexity of data, and the risk of complications or mortality. Okay, and as you go down, you can see, if they have minimal number of problems, you're looking at straightforward. Okay, if they have minimal amount of data, again, straightforward. If it's limited or moderate, it goes up from there, and you can see how the CPTs line up with those. Okay, now in order to pick which one you need, to choose the correct level, it has to meet two criteria, or it has to meet two of the requirements, I think is what they refer to it as. And what that means is they have to have two of the same level in the three elements. Okay, two of them have to match whatever you pick. Like they either have to be two in the straightforward column, two in the low, moderate, or high, and that's going to determine which CPT you're going to be able to use over there on that left side. So it would not be a bad idea for you guys to make note of what page that is on, and you can use that to kind of help you out, kind of help figure things out.
And Miss Brandy, if I can add, if you notice,
Absolutely.
I'm sorry, Miss Brandy, if you can go back to your slide. If you notice your coding, just by me looking at this, I can look at 99202 and see that this is a new patient code. Look, your zeros in your coding are your new patient codes, and then your existing codes has the 1 in them. And your level of MDM, just like Miss Brandy said, it goes 2, 3, 4, and 5 on existing and on established. So the N number goes up as the complexities become higher and higher. Just something for you to kind of know when you're looking for, like, for instance, when you go into your book and they tell you new patient, you're going to go into your new patient codes, and your new patient codes is going to start with 99212.
Yes, that is exactly right. And I didn't even realize that the new patient codes were on there too. I was just looking at the established patient. But like Ms. Danielle was saying, and you'll actually see this on the next slide as well, something I always like to point out to you guys is on page XXV in your CPT manual, at the beginning, before the page numbers even start, you're gonna have all my kids' paperwork from schools everywhere right now, this awesome little table. And I took a picture and blew them up, two of the little sections for y'all. This first one is the new patient, and the second one is the established patient, and both of these are for office visits. Okay, and they have these for observation care, consultations, hospital care, inpatient and outpatient, neonatal and pediatric. I'm just looking at the different ones they have. Initial nursing facility, all the different E&M codes that you will need are basically broken down, so you kind of have this easier chart to go by. And fortunately, most of the scenarios that we deal with in the textbook let you know what level of complexity that you are dealing with. So all you have to do is figure out which one's going to be the right one based on the information you're given. And like Miss Danielle was just saying, you notice the new patient codes are all 02, 03, 04, and 05, and then your established are the 11, 12, 13, and so on and so forth. But I want you guys to notice too, on this 99211, you see how it's NA all the way down? That's because that code is not used anymore. They have decided over the years that it's a complexity level that they don't need. They use the 99212 if it qualifies for 99211 status. It's just not something they do anymore. So that's a change that was made over the last several years that, we've had to make note of when we're coding and billing and whatnot. All right, but these will help you. And again, that's page XXV. And that's where my tabs start in my CPT manual, is before the page numbers, before the alphabetic indexes and all that, at the very, very beginning on the resource pages, because they are really, really valuable. Really valuable. They will help you out a lot. There's a lot of good information there. All right, so let's get into some practice, okay? Anybody want to read the first scenario for us? No? Okay, I'll go ahead and read it. A 53-year-old established patient complains of frequent fainting. The history and examination are documented, and the MDM is of high complexity. All right, so we have a high complexity established patient, and they want us to figure out the CPT code. Does anybody that's here have their books and are able to follow along?
I have my book. I'm following along.
All right, that's awesome, Kelly. Thank you. Let's see, can you go to page, the page I was just talking about, XXV?
Yes, ma'am, I'm there.
Awesome. All right, so in the first column, all the way to the left side of the page, the top box is the new patient, office or other outpatient services, and the second box is the established patient.
Mm-hmm.
All right, so they let us know already that it's high complexity, right? So we're going to look on our chart, and it's high complexity. And they also have, if you guys look, they have medically appropriate history and or examination. I guess that this chart kind of takes into consideration that they would have done that already, that they would have had a medically appropriate history and or examination. So we look at our MDM and it's high, or we can look at how long they took if we had that information, and that's listed out at the bottom of the chart as well. All right, so for a high MDM, which CPT code are we looking at?
99215.
Absolutely. That is correct. Awesome.
Good job. Good job.
Yes. Does everybody see how we got there? I don't know if other folks, I know Kara is brand new. She doesn't have a book yet. Crystal should have hers though, but I think she comes from work. All right, so let's see. Our next one, an established 31-year-old patient presents with an irritated infected skin tag. The history and examination are done, and the MDM complexity is low. All right, so again, this is another established patient, and our complexity is low. So based on our chart, we've got our history and exam and our low complexity. Which CPT code are we looking for?
99213.
That is correct. Perfect. Excellent. Excellent. See, E&M is his own special little snowflake. But it's not, once you get the hang of it, once you go through it a few times and you start working on it and see how things are laid out, it's not that difficult to catch on to. Y'all got this. But I know a lot of people get overwhelmed with it because you're doing things like looking at history and looking at time or complexity levels and stuff like that. So you get a little overwhelmed because they're throwing a lot of information at you. But just take it one piece of data at a time, essentially. All right, so let's look at our third one. A 4-year-old new patient presents for the removal of sutures from an appendectomy incision made 10 days earlier in another city. The physician spent 15 minutes with patient prior to removing the stitches. All right, so we've got a 4-year-old new patient. So we're going to be looking at that other box, not one we were, the one on top. Removal of sutures, appendectomy. Physician spent 15 minutes. So they don't give us a level of complexity on this one, but they do give us a time frame. So based on that time frame and the fact that this patient is a new patient, which CPT code are we going to be needing for this guy?
99202.
99202. Perfect. Excellent.
Don't y'all just love CPT over ICD-10? I could sit here and code CPT all day over ICD-10.
Yes.
Absolutely.
It's so much easier, huh?
It is. There's not so many, like what kills me about ICD-10 is all the little things you have to decipher, all the little codes and symbols and highlights and this and that you have to decipher. That's what throws me off with ICD-10. I find CPT to be a lot more straightforward, a lot more to the point. All right, so this is those same questions with the correct answers next to them. So these are a little bit more. These are a little bit more, okay? All right, so the first one, a 45-year-old man was sent by his PCP to an orthopedic surgeon's office to render an opinion for acute pain and stiffness in his right elbow. In his history, the physician noted that the man was a farmer and used his right hand and arm repeatedly, lifting heavy objects. The patient had no other complaints and reported to be in otherwise excellent health. The patient described the pain as severe and unrelenting, and it prevented him from using his arm. The physical examination noted the man's slightly swollen right elbow with marked pain on movement. No other problems were noted with his right upper extremity. The physician diagnosed the problem as elbow tendonitis and bursitis, recommended warm compresses, and gave the patient a prescription for an anti-inflammatory medication. The MDM complexity was straightforward. Okay, so this is a little bit different. They don't come out and say it outright, but this is not an office visit. What do you guys think this is? Let's see, his PCP sent him to an orthopedic surgeon to render an opinion. So he wanted the patient to do what with this physician?
Second
Give it a
opinion?
consultation.
Yes, ma'am.
Consultation, yeah.
Absolutely, a consultation. They're sending him to see what he thinks, to find out his opinion on the diagnosis, right? So we're looking at a consultation. With an MDM complexity, it was straightforward, right? Because the guy came in with his elbow issue and really nothing else going on. No crazy histories or other diagnoses to look at. So we're looking at a complexity of straightforward for a new patient consultation. Let's see.
99242.
Who said that? Yes, ma'am. Very good. 99242.
Good job, Chastity.
Great job. All right. So the reason I wanted y'all to see these two in particular, because there's a lot of information in these that might not necessarily apply. We got to pick out, we're still learning how to pick out the information that's relevant to us, right? The information that we need to have. So you got to kind of get used to reading these larger scenarios on the work that we're doing and kind of breaking it down into what we are asking for, okay? And for these particular exercises, it's CPT code. I think in the chapter exercises in the book, they actually ask y'all for the ICD-10 code too, but I wanted to focus on CPT today. All right, so excellent job on that one. Very good. All right, so let's hit our last one. A 65-year-old man had recently undergone a prostatectomy for prostate cancer. Since the surgery, his previously controlled atrial fibrillation had become a problem again. A cardiologist was called in for an inpatient consultation. He reviewed the patient's present status, including the duration and severity of his symptoms. The cardiologist reviewed symptoms related strictly to the cardiovascular system. During the history, the physical examination concentrated on the man's neck, chest, and abdomen and attempted to elicit all cardiovascular pathology. The consult suggested that the atrial fibrillation could be controlled better with a different medication. The MDM complexity was straightforward. I have a little box covering the last sentence there. All right, so where do y'all think we're going to go with this one?
So we do know a couple of
Under
factors.
inpatient or observation consultation.
It's going to be an inpatient consultation.
So 99252.
Yes, ma'am.
Good
Very good.
job.
Very good. But y'all see how helpful these little charts and things are? These resources in the book that really help you break things down and make it, to me, it helps it make a little bit more sense to see it lined out. You know what I mean? So, and I think a lot of people learn that way. It makes more sense if you have a visual, something that you can go off of.
So this means you guys, y'all are gonna kill y'all final, right?
Oh, they got that.
Yeah, y'all are gonna kill that final for chapter 11.
They got that all day long. All day long. All right, so after going over those little exercises and finding out a little bit more about MDM, how are y'all feeling about the E&M coding? Y'all been feeling okay about the chapter exercises you've been doing? And
I think from the answers that you guys have been giving, y'all should be jumping up and down saying I am super confident.
absolutely.
You guys did very well with coding those different scenarios and coded them very quickly. So I want y'all to be super confident.
Absolutely, y'all should be. Y'all are getting there, guys. And like I said, every week that goes by after doing another week's worth of chapter exercises and another week's worth of practice and lecture with us and stuff, it's going to click a little bit more every week until one day you're going to go, "Boop,
Yeah.
I got it."
I always say medical billing is kind of like baking a cake. You're just adding the ingredients into it until you get your full cake, which is in billing terms, your claim form that is in its completion in its entirety.
That's a good analogy. I had never thought of it like that, but yeah, absolutely. All right, so do y'all have any questions or concerns for us at this time? Dealing with CPT or anything else y'all may have as far as billing and coding, the program, anything like that?
I have a quick question.
Which guy?
When should we start taking the NCCT classes that you have on Tuesdays? I started in December.
I got you, Miss Crystal. You could actually probably benefit from that now because let's see, if you've been in since December, that means you've gone through 158 through 153 for sure. So you could probably go ahead and take the MOA in CCT and be fine. And that's actually what we're doing right now. What we just started covering was the MOA. So that would be what I would suggest for you for right now. Would go ahead and start hopping on Tuesdays. Download the MOA review guide that I've got posted right under the link for the Tuesday meeting, and start going over some of this stuff, and then take your MOA as soon as we're done with it, and you'll be fresh for it. That'd be ideal.
And I think when we finish
Okay.
with NCCT prep for MOA, you guys definitely purchase your NCCT practice MOA exam. Purchase your practice exam because your practice exam is going to be outlined in the same way that you won't have the same questions, but you'll get the gist of the test. And depending on what you score on there, if you score pretty high on that exam, on that practice exam, schedule that test the next day. That is going to be your telltale sign that you're ready to go and take your exam. When you get to like a 90% on your practice exam, go take your MOA because you're ready.
Absolutely. Absolutely. Those practice exams they're going to tell you where you're at, whether you're ready or you need to review the material a little bit more. And if I'm not mistaken, they even break it down into which categories that you need to that you did well on and which categories you need to focus a little bit more on. So
Yeah.
those, we highly recommend those.
Highly recommend those.
Yeah.
I think like $24 is the best $24 you'll ever spend. Trust me.
Absolutely. Absolutely.
Thank y'all for all the information.
Oh, you're welcome, Crystal. And hey, look, also, that's for the MOA. Now, as soon as we are done with the coding and insurance part, like as soon as we wrap back around to like module 155, 156, you'll be ready for the big NCCT coding and insurance exam right as you're finishing up. So that'll be almost perfect timing for you. Excellent question. Thank you so much. Anybody else got any questions, concerns? Anything for us today? No? Okay. Well, if that is all you guys have for us, Miss Danielle, you have anything you want to throw at them before we let them loose?
No, ma'am. That was pretty much it. You guys are doing amazing. One day closer to graduation. Keep pushing.
That's it. That's it, guys. I had four of y'all finish my program yesterday, so we're having a good week in Miss Brandy's class. Quick announcement though, Memorial Day is May 27th. We are not having classes that day, so just a heads up ahead of time on that. Okay. All right. Well, if that is
All
it,
right.
guys, is that it?
Yes, ma'am.
Okay.
Yes, ma'am, that's it.
Awesome. Well, you guys have a blessed weekend, and we will see you next week.
Bye,
Bye-bye.
y'all.
Bye, guys.
Bye.